Hello, I'm Dr. Nebal Wail, a pediatric neurologist in Children Welfare Teaching Hospital. In this lecture, I would like to present central nervous system infection in children. We are going to list the types of central nervous system infection, explain the etiology of meningitis and encephalitis, review the risk factors for development of meningitis, enumerate the clinical features of meningitis and encephalitis, illustrate the diagnostic workup of meningitis and encephalitis, and we are going to discuss the treatment lines and summarize the complications. Central nervous system infection commonly is due to viral infection. Less common is the bacterial infection, and less common the fungal and parasitic, to be followed by rickettsial infection. It can be either diffused in form of meningitis or encephalitis, or focal type of infection causing abscess. We are going to start with acute bacterial meningitis. Now, the etiologies in acute bacterial meningitis, I'm going to talk about the bacterial etiologies. In the neonatal period, from birth to 28 days of life, Group B Streptococcus, Group D Streptococcus, gram-negative like E. coli, Listeria monocytogenes are the most common bacterial pathogens. Listeria monocytogene should be considered or need to be considered as a cause in the first 3 months of life. But Group B, Group D, gram-negative bacteria, gram-negative bacilli are usually or should be considered in the first month of life, in the first 28 days. From 2 months to 12 years, we have to consider Neisseria meningitis, Streptococcus pneumoniae, H. influenzae type B. Of course, there are other types beyond the discussion in this lecture. Now, H. influenzae type B, the incidence of this type of pathogen as an etiology for acute bacterial meningitis has been reduced by the implementation of the HB influenzae or H. influenzae type B vaccine in the vaccination program. What is the epidemiology? The major risk factor to develop meningitis is the lack of immunity. Colonization with the pathogenic bacteria also is another risk factor. Close contacts. من هم الكلوز contacts؟ قد يكونون بالhouseholds أفراد العائلة, daycare centers, بالحضانة, college dormitories. Those individuals who have invasive diseases caused by Neisseria meningitis and H. influenzae. Crowding, poverty, all these are risk factors to develop acute bacterial infection. The mode of transmission is respiratory tract secretion or droplets through this mode of transmission. Clinical manifestations. The presentation classically are fever, decreased feeding, headache for older children especially. Some of these clinical features cannot be applied or expressed in all age groups. Some of these manifestations need to be expressed by communicative child. So you need to consider this point while listening to the patients or to the parents presenting features. Headache, symptoms of upper respiratory tract infection can precede the onset of the illness. Myalgias, arthralgias, tachycardia, hypotension, these are signs actually. Cutaneous signs, especially in children with infection with Neisseria meningitis. Papilledema, swelling of the optic disc. Focal and neurologic signs, cranial neuropathies. مثل ليش focal and neurologic signs? It could be in form of ptosis, facial nerve palsy, unilateral extensor plantar, focal seizure, alteration in mental status, meningeal irritation sign, and photophobia. Let me focus or let me remind you with the clinical manifestations that some of these manifestations are age, their expression are age or its expression is age dependent. This is important. Not every child can say or express headache or photophobia or myalgias and arthralgia. In younger children, the important presenting features are fever, decreased feeding, alternating mental status. The infant becomes lethargic or irritable, has increased sleeping, or became sleepless and irritable. The child or the infant may develop vomiting, bulging fontanelle, etc. Meningeal irritation signs are very important, but the Kernig sign and the Brudzinski sign are not consistently present. And be careful that meningeal irritation sign may be absent in the infancy period. So absence of meningeal irritation signs of these signs cannot exclude meningitis. Now these irritation signs include knuckle rigidity, back pain, Kernig signs, Brudzinski sign. Knuckle rigidity, if the child lies on supine position, the physician will try to move the head to both sides and then to flex the head so that the chin should touch the chest. In knuckle rigidity, you will find difficulty in flexing the neck. The child should lie supine in this position and the pillow should be removed. Kernig sign with the same position as in the knuckle rigidity. While the child lies supine, the physician should flex the leg to 90 degrees at the hip joint, 90 degrees at the knee joint, and on attempting to extend the leg, there will be pain and contracture. The pain is very important. So please look at the child's face and you should perform this maneuver on both legs. Brudzinski sign with the same previous position. The child lies in supine position. The pillow is removed. On trying to flex the neck, there will be flexion of the hip and the knee, and vice versa. This is very important. And this is, yes, this is very important. Okay. Signs of increased intracranial pressures like headache, vomiting, bulging fontanelle, abducens nerve palsy, which is manifested as convergent sequent, and this is very important sign, non-localizing sign. This is a non-localizing. It doesn't mean that there is a problem in the pons or a problem in the sixth nerve, but it may indicate increased intracranial pressure. The same for oculomotor nerve palsy. Signs like bradycardia, apnea, or hyperventilation, hypertension. This triad is called Cushing triad, and it is one of the terminal signs or the signs that indicate terminal stages of increased intracranial pressure. Decorticate, decerebrate posturing, again, terminal features or terminal stages, and stupor, coma, or signs of herniation. Papilledema is uncommon in uncomplicated meningitis. يعني papilledema not commonly seen in meningitis, but if you find papilledema in children with meningitis, then you need to think of a chronic process like abscess, intracranial abscess, subdural empyema, or occlusion of dural venous sinuses. In this case, if there is suspicion of meningitis and papilledema, then you have to think of these three comorbid problems. Focal and neurological signs is usually due to vascular occlusion, occur in 10 to 20% of children with bacterial meningitis. And we mentioned what the focal and neurological signs. Cranial neuropathies, ocular, oculomotor, abducens, facial, auditory are usually due to inflammatory, focal inflammatory lesion. Seizure can occur in 20 to 30% of cases, and they are usually due to cerebritis, infarction, electrolyte disturbance, especially sodium. Alteration in mental status is caused by increased intracranial pressure, cerebritis, or hypotension. And we mentioned its manifestations. How can we diagnose patient acute bacterial meningitis? First of all, lumbar puncture. This is the gold standard diagnostic test. We have to analyze CSF. Second, blood culture. In cases where CSF is contraindicated or the family refused lumbar puncture procedure, then we can culture blood, and it has diagnostic yield of 80 to 90% of the cases. Neuroimaging has indications, serologic test, and rarely brain biopsy. Now, this is the CSF analysis. You can see that we have to mention the normal values and appearance of the CSF. In the older children, the normal values are clear crystal CSF. The pressure is 110 to 150 millimeter water. It's better to be less than 180. Cells are less than 5. More than 75% of these cell total account, more than 75 need to be lymphocytes. Protein is a 20 to 45 milligram per deciliter, and glucose is should be more than 50 milligram per deciliter, or about 75% of the serum glucose. And this column represent the normal values and appearance of the CSF in neonatal period. Now, in cases of bacterial meningitis, acute bacterial meningitis, there will be increment in the CSF pressure, increment in the cell's total cell count with the predominance of polymorph nuclear cells, increment in the protein amount, decrement of glucose amount less than 40 milligram or 40 milligram or 50%, less than 50% of the serum glucose. The LDH will be increased and the pH will be acidotic. In cases where the CSF glucose is measured, we need to compare it with the blood sugar level. And in this case, it is preferred and recommended to measure the blood pressure, glucose level before before performing the lumbar puncture. In case you forget to do this, then you have to measure the blood sugar 2 hours after performance of lumbar puncture. What are the indications of a neuroimaging? You don't need to neuroimage every child with acute bacterial meningitis. There are indications for this. In cases of signs of increased intracranial pressure, which were mentioned before, focal and neurological deficit, prolonged fever or recurred fever, increased head circumference. What is the treatment? Specific treatment and supportive treatment. But there is a rule for a treatment of children with CSF. We need to capture the pathogen and we need to treat. But is it always in this sequence? No. If there is a rapidly progressing disease but no signs of increased intracranial pressure, then we have to perform lumbar puncture and then treat with antibiotic. But if there are signs of increased intracranial pressure or any contraindication to do lumbar puncture, then we have to treat and postpone lumbar puncture performance. Treatment include antibiotic, corticosteroid, and supportive treatment. The antibiotic, now, in most of the cases, we perform lumbar puncture or we don't perform it. In either case, you will not get the result of the culture immediately. There will be delay, so you have to start empirical treatment. And as we think that, or as we review the pathogens in the children aged 2 months to 12 years or younger, then we have to start empirical antibiotics suitable for this type of the pathogens. So in cases of children, older children, we have to start third generation cephalosporin like rosifin or ceftriaxone and or cefotaxime plus vancomycin. Vancomycin is added for the possibility, the 25% possibility of beta-lactamase resistant Streptococcus pneumonia. This should be persisted or continued for 10 to 14 days. For Neisseria meningitis, penicillin or third generation is preferable and needs a shorter period or duration of a treatment. For gram-negative gram-negative bacilli, we need to start with ceftazidime and aminoglycoside, and it needs longer duration, about 3 weeks. Shall we repeat lumbar puncture? No. It is the repetition of lumbar puncture is indicated in some neonates in patients with gram-negative. يعني patient طلع عنده gram-negative باللمبر puncture الأولى يفضل أن نعيدها بالمرة الثانية. In patient with infection by beta-lactamase resistant Streptococcus pneumonia. Corticosteroid also is given with this dose, and supportive treatment. This is very important. It is as important as the antibiotic. We have to monitor the patient frequently during the first 72 hours. We have to monitor the vital signs, the neurological examination, and the laboratory studies. It's better to keep patient nothing by mouth. If there is increased intracranial pressure, or features of SIADE, syndrome of inappropriate ADH secretion, which is one of the acute complications of acute bacterial meningitis. In this case, in these two cases, we have to start maintenance treatment, fluid maintenance, 1/2 to 2/3 of the total maintenance, and then change to the total maintenance. Admit the child to the, of course, the child should be treated with antibiotic and should be monitored in the hospital. In cases of shock, coma, refractory seizures, increased intracranial pressure, then we have to admit the child to the intensive care unit to be treated there. In cases of increased intracranial pressure, intubate the child and hyperventilate the child. Use furosemide, mannitol. In cases of seizures, we can use diazepam, lorazepam. We can treat, monitor, or measures serum glucose, calcium, and sodium, as these can be disturbed, and treat them. Then we can use phenytoin. There are acute complications and long-term sequelae for in patients with acute bacterial meningitis. And this is the list of complications. For the long-term sequelae, the most important complication that need to be monitored carefully is the hearing loss, carefully and routinely. How can we prevent acute bacterial meningitis? By giving vaccination for certain or specific types of bacteria, and by giving antibiotic to prevent occurrence in other contacts. Now we are going to talk about other type of diffused CNS infection, which is viral meningoencephalitis or viral encephalitis. It is an inflammatory process of the brain tissue. This is very important. For the meningoencephalitis, there is an inflammation of the meninges and the brain tissue. For the encephalitis, there is an inflammation of the brain tissue. It's nearly the same. What is the difference between the encephalitis and the meningoencephalitis is the presence of meningeal signs. The etiological pathogens commonly are enteroviruses. Enteroviruses account for 80% of the pathogens causing meningoencephalitis. Arboviruses, herpes simplex virus causing severe sporadic disease, herpes simplex virus type 2 in neonates, and other viruses. The clinical feature, there is a prodrome of nonspecific febrile illness to be followed by 3 important manifestations: fever, disturbed level of consciousness, and focal neurological deficit. So fever, disturbed level of consciousness, and focal neurological deficits, including seizure. This triad represent encephalitis until proved otherwise. Exanthem or skin rash can occur in the following, in cases of infection with the following viruses: measles, rubella, varicella, ecovirus, coxsackie virus. The differential diagnosis of viral encephalitis or meningoencephalitis are acute bacterial meningitis, TB meningitis, syphilis, Lyme disease, catch-scratch disease, etc. And we have to consider non-infectious causes or non-infectious illnesses, as in malignancy, connective tissue disease, drugs, toxins. How can we diagnose viral meningoencephalitis or encephalitis? By analyzing CSF if there is no contraindication. This is very important. Please, if you consider performing lumbar puncture, you have to search for the contraindication. If there is one contraindication, you have to postpone LP, lumbar puncture. Cells showing pleocytosis, protein can be normal or slightly increased. Sugar is normal, except in 20% of cases of mumps meningoencephalitis. Sugar can be reduced, and the reduction of sugar in the CSF is called hypoglycemia. Viral culture is the easiest to be done for the enteroviruses. Also, we can capture the virus from the nasopharyngeal swab, urine, or feces. Serological test, PCR to analyze RNA viruses like enterovirus, or DNA viruses like herpes simplex virus, Epstein-Barr virus, varicella zoster, etc. EEG usually showing slow wave activity, and the MRI. If you have focality clinically or by EEG، يعني إذا شفنا focal neurological deficit, focal EEG slowing, and focal neuroimaging hypodensity in the CT scan, or hyperintensity in the T2 sequence in the MRI brain, then you have to think of herpes simplex virus, especially if these represent the insult of the temporal lobe. Treatment, specific treatment is available only for herpes simplex virus and varicella zoster and others by using a cyclovir, which is antiviral drug. But the main line of a treatment is the supportive treatment by rest, reduced room light and noise. Pain, we can use non-aspirin containing analgesia. Fever, use acetaminophen. Vomiting, you can use codeine, morphine, phenothiazine. Also, IV fluid, the fluid of the body is maintained, and especially if the child has poor oral intake. In severe cases, you have to hospitalize the child, you have to treat convulsions, cerebral edema, aspiration asphyxia, fluid electrolyte disturbance, and we need to treat cardiorespiratory arrest. And the management lines for many of these points were mentioned in the lecture of acute bacterial meningitis and in other lectures. The long-term sequelae are nearly the same as acute bacterial meningitis, and these include motor incoordination, behavioral disturbance, visual disturbance, epilepsy, hearing loss. And thank you.